Thank you. Just wondering if these slides are the slides set up?
It should be set up on a roll.
Well, those are yours? Did you want to go? Okay, you go.
Good morning, can you hear me? Thank you for having us. First, I'll tell you a little bit about our group, our little box on the org chart, and then I'll talk to you about the regulatory process that we go through in our group. So I'm in the clinical standards group, and our primary responsibility is the development of the conditions of participation and the conditions of coverage for Medicare providers. Basically, those are the health and safety standards that all providers must participate in, must follow to participate in the Medicare program. Our group is a small group comprised primarily of clinicians and attorneys and some writers. And the goal of the conditions of participation is to ensure that there is a baseline standard of quality. We often refer to them as the minimum health and safety standards. And so the goal is that providers provide high quality care and work towards continued improvement. And so while some of the conditions, they do vary by provider type based on the type of provider, there are some common themes, and generally all providers have conditions relating to facility governance, staffing or personnel qualifications, the physical plant, patients' rights provisions, and also quality assessment and performance improvement, or QAPI as we refer to it. So this is a list of all of the providers that are required to meet the conditions of participation, and they are inpatient and outpatient providers ranging from hospitals, clinics, ESRD facilities, RANKES, rural non-medical healthcare facilities, all have to follow the conditions of participation. And the conditions are enforced through the survey process. So as Sherry mentioned earlier, facilities are either surveyed by state agencies or by accrediting organizations to ensure that they are in compliance with the conditions of participation. So because of the broad regulatory purpose that the COPS, that we refer to the conditions of participation as COPS, government lingo, because of the broad purpose that they serve, and the length of time, frankly, that it takes to make revisions to them, we generally do not regulate by disease or device. Rather, the requirements apply across a facility and may apply to broad categories of services, such as nursing services or rehab services. Some of the challenges that we face in making changes to the conditions of participation are we really try to be flexible in making our changes, and that the regulations apply to all types of providers in the category. So for example, hospitals, any requirements that we have on the books for hospitals would apply for huge multi-hospital chains and also for small community hospitals or rural hospitals. So we really have to be cognizant of the fact that the conditions need to be drafted in a way that allows the provider to meet the requirements in a way that best fits their needs. In addition, longevity. We have to consider the fact that many times it takes a long time to make changes for the conditions of participation. And just by way of example, we are now contemplating a major overhaul to the long-term care requirements for participation. And those rules haven't been comprehensively revised in over 20 years. So we have to establish requirements that are going to be long-lasting. So for that reason, we don't necessarily codify best practices of the day, because what is a best practice today likely will not be a best practice 10 years down the road. So those are some of the challenges that we face in working through revisions on the conditions of participation. So how do we come up with making changes to the conditions? Well, first of all, we do continuous internal review and discussion. We do annual reviews of the conditions to ensure currency and clinical relevance. In addition, there may be statutory changes such as the Affordable Care Act, which, as I'm sure you know, was a lot of work and required a lot of changes to the regulations. Administration policies or priorities sometimes require changes to the regulations. Just this past year or so, the president issued an executive order on burden reduction for the entire government. So CMS and the Clinical Standards Group in particular issued a couple regulations that serve to remove obsolete regulations and reduce burden on providers to allow them to have more space and more opportunity to focus on patient care and quality. National issues and events also precipitate changes to the regulations. In December, we just published a proposed rule on emergency preparedness. And that serves as two examples. One is how long sometimes it can take to get a regulation done. That rule was precipitated by the events with Hurricane Katrina. So we have been working on that rule for the past 7 years or so. We just issued it and proposed, and so national issues and events definitely have an effect on the regs. And then changes in medical practice. Now, we do have a statutory prohibition against regulating the practice of medicine. However, changes in the way that care is delivered, we to some extent try to reflect that in the regulations. And just by way of an example, we just published a final rule where we allowed hospitals to structure their medical staffs in a different way. And that was as a result of what was actually going on in the hospital community. So that's an example of that. And then just to speak briefly about how you can get engaged. Well, I'll talk a little bit about the regulatory process. So what we do when we begin to develop a proposed rule, it's a very deliberative, sometimes can take a long time. And as my boss likes to say, a regulation from start to finish can take anywhere from 6 months to 15 years, depending on the priority, the issue, frankly, the political will behind it. So when we begin just a run-of-the-mill change in the regulations, we do research, we do outreach to experts in the community. We do tons of just talking with each other internally, because CMS is, I've been there for a very long time, and it is home to many brilliant national experts on issues that can be kind of esoteric. Sometimes people spend their entire careers working on a particular issue, so we have many in-house experts, so we do a lot of talking with each other. We do research, we do literature reviews, and then we write a regulation, a proposed regulation. The proposed regulation goes through an internal clearance process through various levels of the government. We clear it in-house at CMS. We clear it with the Department of Health and Human Services until the Secretary of Health and Human Services is satisfied with it. And then we clear it through the Office of Management and Budget. So once it's cleared by the Office of Management and Budget, it's published in the Federal Register, and there is generally a 60-day comment period. So we get comments in, and then we do a final rule, which is basically the same process. We go through the same deliberation, the same clearance until the final rule is issued. Once the final rule is issued, there is usually a delay in effective date. Generally on a what we call a major rule, which has a significant economic impact, that delay in effective date is 60 days. However, for conditions of participation regulations, because of the changes that are usually required by providers, we usually extend that delay in effective date. So once the final rule is published, it may be a year or sometimes a bit longer before the rule becomes effective and providers are actually held accountable for compliance. And then just one more note about the regulatory process per se. We have a statutory requirement in terms of when we have to publish a final rule. So for Medicare regulations, once we publish a proposed rule, we have 3 years from the date of publication of the proposed rule to issue a final rule. If we do not issue that final rule within 3 years, we have to basically start all over and reissue the proposed rule and receive public comments again. And just another note, the semi-annual unified regulatory agenda, if you're not familiar with it, is an agenda of all government regulatory activity. And it lists the regulations that each of the agencies in the federal government intend to publish in the upcoming year, and it provides an abstract on each of those regulations. So it's a place to look to see what different agencies are working on. The time frames aren't always exact because, as I said, the clearance process is dynamic and it depends on what else is happening in the various departments. So, but it will give you an idea of what the agencies are working on and when they intend to issue those regulations. So just to speak a little bit about how you can get engaged, as far as our group, the Clinical Standards Group, we meet with providers, professional associations, all the time on an informal basis. Folks call us up and they say, we have an issue we'd like to discuss with you, and we meet with them. People send us data, letters, correspondence. So it's really an informal process. That's the one way to just call us up, basically. And we are very open to talking to folks. The other, and I would think the most important way in terms of regulatory activity to become engaged is to provide public comment on the proposals that we issue. And that's important because we rely on those comments in developing our policy and refining our policy. When we issue a proposed rule, many times it changes based on the public comments. Sometimes we completely reverse what we have proposed. So it's really important that we receive public comments, and the most helpful public comments are those that contain not only opinions, but data and evidence that support the opinions. That's very important to us because under the Administrative Procedures Act, our policies have to be supported by sufficient rationale. So to the extent that we have data, that we have studies, that we have anecdotes, that we have some evidence, is very helpful to us in making our policy decisions. And then I would think another point I would raise is that when advocates and members of providers come to us, one of the things that I think would be helpful is if sometimes folks need to consider what they are actually asking us. And is it something that we can actually help you with? For example, we are bound by the Social Security Act, by the provisions of the Social Security Act. So sometimes what folks come in and ask us about, we really don't have the authority to change. One example would be perceived or actual barriers to care. We're frequently approached by professional associations saying, you know, we can't practice in this type of facility, or our scope of practice is limited in a nursing home or in a hospital, and what can you do to help us? So in many cases, that limitation is as a result of the statute. So in some cases, it may be better to seek legislative assistance as opposed to regulatory assistance from CMS. So that's something to definitely keep in mind. And then finally, I would just say, in terms of regulatory work, patience is key. The work that we do has a broad impact, a national impact. So when we are approached from the community and we, presented with problems, we definitely consider them, all the information we get, but it's a time-consuming process because we want to get it right. And so be patient with us. Thank you very much.